Our next speaker is one of my friends and colleagues, Dr. Laura Fisher, who is our bariatric surgeon here at OU. Very briefly, Laura did her fellowship at Oregon and then did, and then residency there in Michigan. She has been heavily involved with weight loss surgery and as well as studies and promoting that and the link between obesity and cancer risk.
I was asked to kind of go over how bariatric surgery fits into the context of treating adolescent obesity. Just to state that I have no financial disclosures or any relationships that would affect this talk. So I'm going to just try to kind of paint a picture of how bariatric surgery fits into a multidisciplinary treatment program, review some of the data that is out there on the health benefits of bariatric surgery for adolescents, go through some of the physical, behavioral health, and social challenges in providing bariatric surgery, and then identify which is hopefully helpful to you guys, which adolescents might be the most appropriate for a referral. So, everybody knows that obesity is one of the most common chronic pediatric diseases. And it was first defined as a chronic disease by the NIH in 1998, and then the American Medical Association in 2013. And that information has not really made it into our kind of cultural consciousness yet. And the majority of what you will see on TV or the internet essentially tells all of us that if we have obesity, that's because it's our fault. And that if we just worked harder, we wouldn't have it. And hopefully, if you are not convinced, some of this will help to convince you that that is true. And for adolescents and adults, obesity is much more common for people who have a lower socioeconomic status, for people who have childhood traumatic events, and other negative social determinants of health. So there are, 20% of children and adolescents in the United States have obesity. And the prevalence increases as age increases, and also it's a higher prevalence in Hispanic and Black children. The causes are multifactorial, but the primary cause of obesity is probably genetics. So we think probably at least 40 to 70% of obesity is caused by your genetic background, parents, grandparents, aunts, uncles, and conceptually, in our field, we think of this as an evolutionary advantage that helped people to survive when we did not have a food source that was reliable. And so being able to store excess calories as fat was something that allowed people to survive and, have their genetic heritage pass on. But now we live in this society where we have unlimited access to unlimited calories. And the calories that are the least expensive are the ones that are primarily fat and sugar in fast food and highly processed foods. So genetics, our environment, we watch a lot of TV, we sit at computers, we are not getting outside and playing as much. It's very expensive to buy fresh vegetables. It's expensive to buy healthy, lean meat that's organic. And it's also expensive to have time to cook. So if you are a single mom working 2 jobs, it's really challenging to prepare for fresh food. And so then you tend to move towards the ultra processed foods that are associated with obesity. And then, there are a lot of medications that can promote obesity, and usually it's the medications we use to treat the obesity-related health problems, like insulin, for example. And then obesity has a very strong connection with emotional triggers. So things like boredom, stress, anxiety can lead people to want to eat. So this is just a snapshot of all of the health problems that are related to obesity. And the majority of these in adults have been linked directly to obesity without any other factors being considered. And the general idea is that adipose tissue is a very active organ, and that it secretes cytokines and other hormones that promote obesity. So there's a lot of free fatty acids, a lot of inflammatory cytokines, and then of course estrogen is produced by adipose tissue. And so all of these substances go systemically throughout the body and cause end organ damage to all of these systems. So when we think about treating obesity, since it is a chronic disease, many of the things that have been tried in the past, if it's just a single kind of pathway of treatment, just doesn't work. So people tried to create a ghrelin analog or an anti-ghrelin analog to block it so that people don't get hungry, and it absolutely doesn't work. So in general, for me, when I think about how I treat obesity, I think about it the same way as treating cancer. So if somebody has cancer, we treat them with surgery, a lot of times, chemotherapy, most of the time, radiation, immunotherapy, and all of these things have to be very carefully tailored to each individual patient and what their specific problem is. And so it's the same with obesity. So we treat obesity with dietary intervention, exercise interventions, weight loss medications, and surgery. And when we provide these treatments, because two of the treatments are behavioral, we really do need to be very careful to use non-stigmatizing language and in general try to express and treat patients so that they understand too the belief that this isn't their fault, because that kind of thought pattern is really destructive to making positive behavioral change in the future. So as part of this collaboration, surgery is an adjunct to the other therapies that we use for obesity, and it's very powerful. So in terms of adolescent surgery outcomes, one of the probably biggest studies that I actually had the pleasure of working on was not Teen Labs, but the lab study. So this was a very large NIDDK funded study that lasted about 13 years. And they recruited 242 adolescents from 5 different US centers and followed them for 3 years after surgery. And labs was very structured. They had, multiple surveys. Everything was very carefully administered by research nurses and coordinated amongst all the different centers. And they had 99% follow-up, which is very unusual in bariatric literature. And so in this particular study, they were looking at just the gastric bypass and the sleeve. And they wanted to look at the different outcome measures to show, is it effective? Is it safe? And what kind of results are we going to get? Is it the same essentially for adolescents as it is for adults? Because we have a lot more data in the adult literature, but we needed to show that it was the same for adolescents. And so they were able to show that these patients lost about 27% of their total body weight after surgery. And it's pretty common to have a bit of a weight nadir and then a little bit of a bounce back. And we see that it's actually the same between adolescents and adults. But then once you kind of hit that nadir and you plateau, people can keep this weight off. And in adults, we have data over 30 years showing weight stability. And so in this particular study, almost every single participant had a BMI over 40. The majority were from households with an income less than 50,000. And in this patient population with this kind of weight loss, 26% of the patients actually no longer had obesity, and that was maintained at 2 years. And then when they looked at all of the other kind of non-weight related outcomes, They found 43% resolution of hypertension, 95% resolution of type 2 diabetes, which far exceeds what we see in adults. And then 66% resolution of dyslipidemia. The gastric bypass group lost a little bit more than the sleeve, which is pretty consistent with adults. And we're not sure if that's clinically significant. And then the adverse effects were, the standard kind of the nutritional deficiencies. So iron deficiency, vitamin B12, D3, calcium are kind of the primary ones that we look at. Folate and thiamine as well in adults. And then I was actually surprised that they had such a high rate of additional procedures. But they are categorizing all gallbladder removals as part of an additional procedure, which I'm not sure is entirely accurate, but they did have one death, which was a patient with type 1 diabetes who died 3.5 years after surgery from a hypoglycemic event. And so the really high rates of resolution of diabetes, dyslipidemia, and hypertension in this patient population kind of got people thinking about, can we help prevent these diseases at an earlier age, right? I get referred patients all the time who are 65, they weigh 600 pounds, they cannot walk, they are trached, they have all sorts of medical problems, and it's like metastatic cancer. It is end stage, and I cannot treat that person in a way that's going to get them to a functional quality of life. I can help, but it's just not the same as taking an adolescent who weighs 400 pounds and getting them to a normal weight and then having them stay at that normal weight for the rest of their life. That is kind of one of the things that really has us thinking in the bariatric world is, when do we want to intervene? This study was a Swedish study, and they do a lot in the bariatric world because they have a nationwide registry. So their follow-up is always 99%. And they compared 100 adolescents who 81 had a gastric bypass, and then matched them to adolescents receiving medical treatment, and then adults having gastric bypass. And followed them prospectively. And they were followed out to 5 years. And here you can see, and these weight loss curves are exactly what you will see in every single randomized controlled trial of bariatric surgery compared to intensive medical therapy for obesity, in that the control group gained weight. They gained about 3.5% of total body weight over the 5 years. And the adolescent and the adult groups both lost about 28 to 29% of their total body weight. And in this data, they also had a crossover of 25% of the medicine group ended up asking to have bariatric surgery because of the results seen here. In this patient population, 69% of the adolescents and 85% of the adults were actually able to achieve more than 20% total body weight loss, which is really amazing. And I just did a journal club last week with Dr. Aaliyah Minion, who does a lot of research out of Cleveland Clinic, and he published a paper in JAMA about the relationship between obesity and cancer risk. And in their study, which was about 30,000 patients, they did not see the benefit until patients had actually crossed the 25% total body weight loss mark. And so losing 5%, while it's good for your heart, may not be enough to really get you the benefits of things like cancer reduction. And it also took 6 years to see the result. It was a 10-year study. So in this study, you can see the gastric bypass adolescents lost about 28% of their total body weight, and the medical group gained weight. And their A1Cs are similar. So this group did not have a high baseline level of type 2 diabetes, but the dyslipidemia markedly improved in the bypass group, the hypertension markedly improved, and then the adverse effect of the iron deficiency is seen in the gastric bypass group. So in this study, which is another study out of Teen Labs, but it specifically looked at diabetes. In this study, they compared the adolescents who had bariatric surgery to a group of randomized adolescents from the Today study, where they were randomized to metformin alone, metformin plus rosiglitazone, or metformin plus intensive lifestyle therapy, and then followed them out 2 years. And you can see at baseline, the bariatric surgery group had a much higher baseline BMI than the medicine group. And they also had a much higher rate of insulin-dependent diabetes because the medicine group, by definition, had to be on metformin only for enrollment. And so here is another comparison of the weight loss in the surgery group compared to the weight gain in the medicine group. This group, again, gained 3.7% over 2 years, and the bariatric surgery group lost 29% of their total body weight. And then here is just a comparison of some of the other markers. And I think, some of the things that didn't change in this group was the systolic blood pressure, but the triglyceride level, I think, is pretty different. The fasting glucose, of course, is extremely different. And the A1C dropped from 6.8 to 5.5 in the bariatric surgery group and went up from 6.4 to 7.8 in the Today group. And in this Today study, the 3 groups, actually, their mark of treatment failure was a hemoglobin A1C over 8 for more than 6 months. And they had very high rates of failure. It was over 50% in the metformin group. It was 45% in the metformin plus lifestyle, and it was about 36% in the metformin plus rosiglitazone group. And I'm not saying that we're not doing a good job. I'm just saying that bariatric surgery is very, very effective for diabetes in adolescents. And I think that bariatric surgery really got a bad rap about 20 years ago because there were a lot of people doing it who didn't know what they were doing, and it was dangerous. And that is very different nowadays. So we are trying to do a lot of work to, promote these things. This was a study that specifically compared adults and adolescents. And they also had 5 years of data. And this is not the best study. I will admit it's retrospective. It's out of the Middle East. The data is a little funny when I was looking at all the numbers, but there's not a lot of 5-year data on adolescents. So this is one of the few. And so in this group, you can see that the adolescent group, at 1 year, they lost from 47 BMI to 36, and then it persisted and they got down to 30 at 5 years, which is really amazing. And in the adults, they got down from 48 to 33 and then 32. And so this group, the adolescents, actually did much better than the adults. And their resolution of diabetes at 5 years was 62.5%, which means no medications at all. And 87.5% were able to get off all of their medications in the adolescent group. The adults did not fare as well. And I am not an endocrinologist, but the way I think about it is by the time an adult has been diagnosed with severe insulin-dependent diabetes, you've kind of burned out their pancreas quite a bit. You can improve insulin sensitivity, but you're not going to make the pancreas start working better with bariatric surgery. So I think in adolescents, that's potentially not true. So other comorbidities for adolescents, a huge number of patients who seek out bariatric surgery have obstructive sleep apnea. In adults, it's about 80%. In adolescents, it's somewhere between 50 to 70%. But the resolution rate is about 65%. And that means in AHI less than 5. Fatty liver disease and NASH, which is now the #1 reason for liver transplant in the United States, has been shown in adults to have an 85% resolution with bariatric surgery. And then for NASH, a 34% improvement in fibrosis. Intracranial hypertension is another disease that is precipitated by childhood obesity and is seen in mainly women in their 20s, but it can lead to blindness. And then orthopedic disease in adolescents, specifically Blount's and slipped capital femoral epiphysis, which I think, do people call that skiffy? Skiffy, yeah. As I said, I'm not an endocrinologist or a pediatrician. So there have been case reports of Blount's regressing with bariatric surgery. And then with skiffy, it has been shown that the surgery for that has better outcomes if they've lost weight. And then if they have it unilaterally and have bariatric surgery, it can prevent bilateral disease. So a lot of what goes into adolescent obesity treatment is really looking at their social situation, the family, the context in which they live. And a lot of people, including parents, don't really recognize that obesity is dangerous. The majority of people think, oh, it's not a big deal. They'll grow out of it. And the majority of patients in this study, or parents in this study, really felt that surgery was actually inappropriate for children under the age of 18. And it did not matter if they had personally had bariatric surgery themselves. So parents who had bariatric surgery still thought it was inappropriate for kids. The vast majority of families in these multiple studies have very dysfunctional communication, dysfunctional patterns of interaction, which I'm like, okay, yeah, doesn't everybody? But I think the thing that I really find interesting is that there is a very strong correlation between childhood, physical and sexual trauma and obesity. And we see that all the time in the adult patient population. In terms of adolescents in particular, having obesity really does affect their quality of life much more than the parents recognize in terms of being able to make friends, feeling comfortable in their friend groups and with their peers, being able to date, being able to fit into seats at a movie theater, stuff like that. Really does affect people very profoundly. And there's a lot of social anxiety disorder and things like that in the obese population. About 25% of adolescents have binge eating disorder or report symptoms of binge eating disorder. And these patients are very challenging and tend to do poor with bariatric surgery without intense cognitive behavioral therapy. Substance use is something that we really worry about in adults. The rate of alcohol use disorder is much higher than the general population in bariatric patients, and specifically in gastric bypass, because the breakdown process of alcohol is bypassed with a bypass. And so it shortens your dose response time, and it really increases the addictive properties of alcohol. And so it's about 10% of adults will develop alcohol use disorder after gastric bypass in large population studies. Depression is, of course, very closely linked with obesity, and it's about 30% in adolescents. And mental health should 100% not be a contraindication to having surgery. The same physiologic or pathophysiologic processes that are happening that give you coronary artery disease and fatty liver disease can also affect your mood and mental health. And so we see all kind of mental health issues as something that we need to help the patient manage rather than as being a contraindication to having treatment. So For adolescents, the criteria for having surgery is that they have class 2 obesity, severe obesity with severe comorbidities, or class 3 obesity with moderate comorbidities. In the ASMBS guidelines, which is the surgical national organization, they have removed bone growth as a contraindication for having bariatric surgery. There's not a ton of data, but there was a study that showed that children actually grew more after having surgery because of their increase in health. But in general, we tend to prefer to do these procedures on patients who are near their adult height and have, advanced the majority of the way in terms of their development. A lot of what goes into assessing and treating someone for obesity is very important for a successful surgery. We like to say that surgery is a tool and it's always there, but if you don't combine it with the other treatment modalities, then it's not nearly as effective. And you can actually have recurrence of obesity if you are, drinking a large frappuccino from Starbucks every day. Even if you have a sleeve, 1,000 calories a day is really hard for our genetics to overcome. And so you can still regain weight if you're not following a somewhat, healthy diet. So in terms of some just kind of a list of the treatment options that we use for obesity. So obviously weight loss medications, and this is a very exciting evolving field that I know you all probably know way more about than I do. But the GLP-1 agonists and the GLP-1 GIP agonist, tirzepatide and semaglutide, are probably going to change how people look at obesity treatment because they are so successful. And the other weight loss medications that we've used in the past have really a lot of issues with them. Orlistat is very poorly tolerated. Phentermine is very addictive, and you can't use it if they have any hypertension or other cardiac issues. Contrave, great idea. No one tolerates it, at least in adults, like no one. They hate it. It makes them feel terrible. We can't get anybody to stay on Contrave. And so really these injectable GI hormones are a very powerful adjunct to our other treatment options. And I'm very excited to see how things develop. Endogastric balloons have been used in adolescents, but the issue is that they have to be taken out after 6 months. And so my personal opinion is that the weight loss effects on these is really temporary and it's very expensive. And so this is not something that we would primarily use in adolescents. In terms of surgical treatment options, the most popular surgery that we do is the sleeve gastrectomy. And this has now become the most popular surgery for adolescents because it does have less malnutrition risk than the gastric bypass. The thing about the sleeve that is just gives me a little bit of pause is that it does cause a 15% de novo GERD. And there's a study out of Italy a couple of years ago that showed 17% new Barrett's esophagus in sleeve patients who had previously not had any esophageal disease. And so I do worry about the long-term effects of acid reflux exposure and the development of esophageal cancer. And then sleeve patients do have a higher rate of recurrence of obesity. And it is what it is. So the gastric bypass seems to have a little bit more durability into the decades. The gastric bypass, we make a tiny pouch at the top of the stomach and we cut the intestine in half and we bring up the distal part of the intestine. And so conceptually, how we think this works is that when you eat, your food is directly stimulating the distal intestine, not proximal. And so all of your stop eating hormones are being upregulated, which includes GLP-1. And so when you have a gastric bypass, you're basically faking out your brain to think, oh, I'm already full because the food is hitting the ileum really, really quickly. And we think that that's the primary mechanism, which is why this is a metabolic surgery rather than just a restrictive type of operation. Obviously, people do get nutritional deficiencies with this. You have to be very careful. You have to take vitamins for life. Some of them can be very serious, particularly B12. And you cannot take NSAIDs with this. And so that is something that you really need to discuss with any patient who's considering having a gastric bypass, because it causes ulcers, which can perforate. And that's the primary kind of long-term risk of this operation, besides the nutritional deficiencies. So this is kind of a treatment summary. I've not heard of anybody doing SADI or duodenal switch on adolescents, which is why I didn't talk about it. But those in adults, SADI and duodenal switch have 90% remission of diabetes. And so those are definitely on the horizon to be the major diabetes treatment option in terms of bariatric surgery. The gastric bypass at 5 years is about 65% remission, and that's under the strictest definitions from the Stampede trial. It's 6.0 A1C, no meds at all, and normal fasting glucose. So that's pretty good. And in the Stampede trial at 5 years, 92% of patients who started that trial were still off of insulin. So conceptually, a pediatric bariatric surgery program really focuses on the intensive family-based behavioral and lifestyle treatment interventions. And so you're meeting with a dietitian, a psychologist, physical therapist, and then of course, an obesity medicine specialist. And a lot of the treatment is to try and teach the patient how to make healthy food choices, how to be, self-motivated in terms of exercise. And then if they are able to be compliant with these lifestyle interventions and are not successful in losing weight, surgery is the adjunct to those that can allow them to achieve, the 28, 29% total body weight loss. For this patient population, it's really important to understand kind of all of the nuances of informed consent and what this really means. When people decide that they want to have bariatric surgery, they're so excited that they want to sign up tomorrow. And our program on the adult side takes 3 to 6 months to get through, and people will be upset about it. And I always tell them, like, I really want you to think about this. This is a permanent operation. I can't take it back. It has very significant impact on how you eat. And you can't you can't eat normally after you have surgery. Your stomach will not let you. And for an adolescent who, eating and going out with their friends and going to McDonald's or whatever, that stuff is really important to them. And so you really have to work with them to help them understand that you can do all those fun things and you don't have to eat the French fries, for example. But in general, parents underestimate how it feels to have obesity as a teenager as compared to the teenager themselves. And so if a parent does not agree that a teenager needs to have surgery, that's not necessarily an absolute contraindication to pursuing that as a potential avenue. Obviously, it's ideal if everybody's on the same page. But, we definitely have patients who sign up for our program like the day they turn 18 because their parents wouldn't let them. And that's kind of a shame. But one thing that it's really important for parents to know is that if your child has obesity as a child, that they are almost certainly going to have obesity as an adult. And in adult studies, the mortality benefit from bariatric surgery is 60%. And the mortality benefit from dying from complications of diabetes is 92% risk reduction from having bariatric surgery. And so if we can treat people before they develop end organ damage from these obesity related diseases, we are actually going to extend their life by decades. This is the coolest thing that has happened in Oklahoma in the last 5 years. When I got here in 2016, Sooner Care covered bariatric surgery, but only if you had diabetes or you needed a joint replacement or you had pseudotumor cerebri, which is rare. And you had to have obesity listed in your medical chart for a minimum of 5 years. And you had to do a diet and exercise program with your PCP for a minimum of 6 months. And it all had to be documented with daily exercise logs and food logs. And you had to do a prior authorization, and they denied all of them because if you didn't lose weight doing that, they said you weren't trying hard enough. And if you did lose weight, they said you don't need surgery. And so basically no one could get surgery through Sooner Care before September of 2021. And so I, spent a lot of time talking with the OCA group and sent them a lot of our data on safety and efficacy. And we talked a lot about kind of guidelines and stuff. And they actually rewrote all of the bariatric coverage guidelines and did a huge literature search. And when they came out with it, I was actually shocked because it went way past what we had even hoped for. And we now have the most progressive bariatric surgery coverage guidelines in the United States, which you don't hear that a lot in Oklahoma. But they cover patients down to the age of 15, and they cover down to a BMI of 30, which is like almost unheard of. And they got rid of the restrictions on comorbidities. So if your BMI is between 30 and 35, you just need 2, or you can have severe metabolic disease. I don't know what that means, but that is what they wrote. So that is very vague, and I can work with that. And then if your BMI is between 35 and 40, you just need 1 comorbidity. And if your BMI is 40 plus, you don't need any, which is fantastic because adolescents often don't have any because they haven't had time to develop them yet. And they expanded their services for bariatric patients to include all of the things that help to make surgery safe. Previously, they had not covered sleep studies or CPAPs, and now they do. They cover physical therapy, up to 13 visits a year, and they cover all of the psychological evaluations and everything, all with little to no copays. So this is a fantastic guideline. If you have any curiosity about bariatric surgery, it's from the ASMBS, which is the Society of Bariatric Surgery. And they updated their practice guidelines in 2018. Like probably due for a new one in the next year or 2. But really, bariatric surgery is extremely safe. The mortality from bariatric surgery is less than 0.5% in all patients, including very sick adults. And in children is much less than that. It's actually safer to have bariatric surgery than to get your gallbladder out in the United States. And it really should be part of a treatment program that is considered standard of care. This is not what we do for the worst possible case of obesity you've ever seen. This is something that is an extremely effective treatment option. It is not crazy. It is just really effective. And I think the more that we can educate people about how surgery fits into these treatment algorithms, the better off the children of Oklahoma will be. So I'm happy to take any questions.
Thank you very much, Laura. We have time for maybe 1 or 2.
Yeah, I think the last thing you were talking about, basically getting approval, is the key to the whole thing, because this data was out. In fact, we had it presented 6 some years ago or whatever. And it just struck me as once the BMI gets to a certain point, certainly mid 40s or something, there's no win waiting. They become people, the likelihood that they're going to correct it goes way down.
Absolutely.
They're only going to become a worse surgical candidate as time goes on with more damage. And what's the point of improving a BMI from 55 to 45? When you might be able to get it from the mid-40s down into the 20s or something.
Yeah.
When they're young.
Yes.
And so I started referring people all the time once if they were 35 or over with comorbidity or 40 with no comorbidities. And there was a program at UT Southwestern. I work at Cook's, down the highway, and we don't have any type of surgery like this. And at first the kids were getting through, but the last few years, the vast majority of the ones I send over there tell me they get turned away, often without being seen, even just discuss the pros and cons, let alone have anything done. You did. And it's because of getting approval.
Yeah.
And it seems to me it's more costly to wait with less benefit.
Oh, yeah.
I mean,
Yeah.
the
The
logic-
ROI on
the logic
bariatric
of
surgery is
waiting
3 years.
is not there
So,
from a
yeah.
medical, moral, or economic point of view. So I just don't see why we have the roadblock.
Well, I mean, I think the roadblock for me is the roadblock is that people still think, they strongly believe that obesity is the fault of the person who has it. And if they just tried harder, they wouldn't need to have surgery. So why should I, United Healthcare, pay for you to have a $30,000 surgery if you could just eat more salads? And it's a fundamental misunderstanding of the disease and how it's genetically based and environmentally based. So yeah.
Society of predisposition genetically,
Mm-hmm.
things like that. It's still there. It'd be like rather say to someone, well, you have lung cancer because you smoke. So if you would stop smoking, your lung cancer is going to go away.
Mm-hmm.
It's already cancer.
Yeah. Yeah, you're preaching to the choir.
I think guys,
Yeah.
but I don't see you sound like you were very successful.
Yeah.
Getting it turned around.
Yeah. I mean, the people at OCA were very receptive to listening, and their main concern was safety and efficacy. And they were worried about the quote unquote sleeve factories, right? So setting up shop, you see them a couple weeks, you do a sleeve, you never see them again. They lose weight for 6 months and then they regain everything back and then some.
What do you think is overall the best surgical approach, especially for like young adults?
You know, I really think it needs to be tailored. Mm-hmm.
When you showed the need for extra procedures,
Mm-hmm.
how does that break down, separate bypass from sleep?
Bypasses tend to have more secondary interventions for things like ulcers, strictures, internal hernias. I think the more we learn about the technical nuances of doing the cases, the lower those will continue. However, the caveat to that is that I am doing a ton of sleeve to bypass revisions right now for severe acid reflux and severe esophagitis and Barrett's. And so I do think that that is something to just keep an eye on, because essentially the majority of people doing adolescent bariatrics, they're doing the sleeve to try to limit or limit the nutritional deficiencies.
Does it make a difference, surgery, like how much of a sleeve you make or how far you stay away from esophageal junction?
Hard to say. Hard to say. We are actually looking at that right now in ASMBS to do a large multi-institutional prospective study.
Okay.
Yeah.
Thank you so much.